everyone, my name is Jamie Lesage, registered nurse, and I will be presenting on fall prevention and hospitalized patients. Let me share my screen. So as you look through the PowerPoint here, what is the clinical problem? The incidence of falls among patients continues to be a frequent problem for our healthcare system today. Falls occur in the hospital and are also the #1 reason for bringing older patients to the hospital. Lack of implementation of a fall screening tool and contract with patients, along with additional education to patients and medical surgical nurses, contribute to falls among many adult patients, mostly the older population. Consequences of falls can lead to patients requiring almost $10,000 of additional costs and care from accidental falls. So this leads to billions to our healthcare system today. And only half of the seniors who have a severe fall will live past a year from the fall. Current practice, safety is a huge concern, especially with JCAHO accreditation that hospitals like to maintain, especially for getting reimbursement from insurance companies. However, current practice may be placing a sign up on a patient's door in room to alert staff, families, everyone that comes in and out of the room that the patient has a fall risk is a common practice. Maybe having a wristband on the patient, especially if they're on certain medications that contribute to imbalances. Sometimes they'll have a sitter sit with the patient. However, with these preventative measures, falls continue to be an issue. So we have evidence-based practice that can decrease falls, which is definitely necessary. Implementation of evidence-based practice has been studied and is really necessary, especially due to Medicare and Medicaid that came up with this policy that will not reimburse care necessitated due to accidental falls. They're called never events. They're never to occur in the hospital. However, they continue to be a huge problem. My PICO question: in adults receiving care in the hospital, what effective implementation of a fall screening tool, along with additional education to patients, in comparison to no implementation of a fall screening tool and no additional education on a reduction in patient falls and increased patient compliance? There were some interesting studies, mostly randomized controlled trials, which are the best with evidence-based practice. There was a study of a fall risk assessment scale along with software with fall prevention interventions that were specific to patients' needs that were shown to be effective. In many of these adult patients, the intervention tool included patient education with handouts and also showed to reduce falls. Another study showed that additional education, including the teaching of exercise as an intervention for fall prevention, reduced the severity of injuries of falls. And that should be included in this additional education. Engaging with the patient in a positive and timely manner with a person-centered approach also influenced reducing falls and fractures, using motivational interviewing techniques, having consistent support and showed to be effective. Patient education, including reminders, along with case management and staff education to the team, could prove successful in reducing the risk of falls and injuries from the fall. Case management was also shown to be important, just making sure that the interventions are completed with the patient. And this was all included in the synthesis of all the evidence-based practice researched for this project. The implementation plan was laid out with approximately showing that the project taking about a year from start to finish. The first 3 months would include research and project goals set by the team leader. Following 3 months would be a simulation of the EBP team. Looking over my slides here, we have management of key stakeholders. Me as the team lead would acquire the articles, getting approval from the internal review board, going over the PICO with my EBP mentor, through literature search, retaining the studies, discussing with EBP mentor. Next step would be summarizing the research, proposing the purpose of the project with outcome measures, showing a 15% reduction in patient falls from implementation of interventions with positive correlation would include a minimum of a reduction of 15% of less falls in the group receiving interventions proposed in the EBP project. We have our data collection protocol. And finalizing all the necessary approvals for the project. Comparing that with further consultation with the EBP mentor. Moving on to the next slide, our cost benefit analysis. Consequences of falls can lead to patients, as we mentioned earlier, costing about $10,000 of additional cost per patient. So as we compare this with the project's cost to be estimated at $10,500 and the projected 15% decrease in falls at approximately $10,000 per patient, it would save the hospital money. If there were 11 less falls total during 3 months, the savings would be $95,000. So it would start to save the hospital money after just 2 less falls. They would start to save money and it would be huge savings. Our SWOT analysis. Strengths, there were many strengths to this project, especially with EBP already being a huge factor, or I mean safety being a huge factor for hospitals. So as we look at the cost assessment and risk analysis is in favor, especially with Medicare and Medicaid and the huge policy, the policyholders have made a lot of restrictions on hospitals for getting payment from these federal and state programs. So this is definitely necessary. We have opportunities, looking at threats and weaknesses. Rolling out a project can be hard, especially for staff that is not trained in EBP. I'm just going to check I don't know. Other threats could be other projects that could be we could be competing with that the hospital's rolling out. We would do a poster presentation with dissemination of the initiation of the project to the stakeholders. And funds would be allocated to provide additional staffing of 2 additional hours per adult patient for the fall screening tool and additional education to the patient, which could a lot of times be implemented in a normal shift. However, allocating these 2 hours would help to really emphasize the importance to take to educate the patient and do the interventions. We would do further meetings to discuss the project's success at midpoint with stakeholders, communicate through email, and then staff would continue with continued training by completing modules during in-services along with other required updates and annual training requirements. Here, we conclude to say that falls continue to be a huge problem in the hospital today. Evidence-based practice research has shown that implementing additional interventions can, let me go back to share my screen here. Having this research and implementing these additional interventions can help to reduce falls. And getting the hospital stakeholders to approve the project, mitigating any concerns, weaknesses that might come up at the meeting would be easily done with showing all the strengths of the project. And then going on to my references, you can see my references. So thank you for taking time to see the necessity of adding additional evidence-based practices to decrease falls and keep hospitals in business. Thank you.